All right.
Hello, ladies and gentlemen. Welcome to tonight's MD Roundtable with Dr. Frame. Dr. James Frame is our lead medical director, and he's got an interesting set of topics for you tonight, and we'll be hopefully keeping this as a running saga over the next two roundtables that he does. And this is a very, very deep subject tonight, folks, and it's one that you have to be good at. So you've started and attending on a very good night. Dusty says he's on duty again, so Dusty, do your best to stick around. If you have to leave, please type in that you're leaving so we'll know. Everybody else, keep your microphone muted unless you have a question. Then you can unmute, get Dr. Frame's attention, or if he has questions, because he'll check in with you a couple of times during the roundtable and at the end to make sure you're still here. We don't want to give you credit for something that you haven't been here for. Now, Dusty, I understand you're on duty, and you know, if you leave out and you put a note on there that you've got a call and you've done most of this, then I'll probably give you credit for it because I don't want you to miss out on that. But try to be here for as much as you can, Lord willing, on the 911 tones. That having been said, Dr. Frame, I'm going to turn it over to you.
Well, thank you, Jane, and I appreciate everybody being here tonight. Jaron and Dusty, I understand that you're both on duty tonight, so if you have to bolt, you know, you do duty first. So anyway, as Jane has graciously introduced me, I'm Jim Frame. I'm your lead medical director and attending physician at Wilson & Jones Medical Center, where some of you hopefully will do your rotations with me in the emergency department there. Some have done them when I've been coming off a midnight shift, so sorry that I've missed some of you, but what we're going to talk about over the next 3 months now will be pre-hospital pharmacology. Now, the reason why I'm emphasizing this is I'm part of the committee that writes questions for the National Registry, the test that you'll be taking on computer at the completion of the entire course. And subsequently, the emphasis over cycle 6 now is, which is the new cycle that we're coming into with questions, is going to be on sepsis management, pneumonia, COPD, asthma, and what we're going to do as far as airway management. Now, given that most, if not all of you have done at least some introductory form of airway management as EMTs, where you've used oropharyngeal airways, nasopharyngeal airways, or maybe even LMAs or King airways. These are all EMT skills. If you've been with a more progressive medical director, the EMTs have been signed off and trained in the administration of albuterol, aspirin, nitroglycerin, sub-Q epinephrine, and LMAs, King Airways, IV starts, AED use, et cetera, et cetera. So there's about 8 areas where Texas EMS medical directors are allowed to certify their EMT students, EMT certified EMT personnel to do enhanced care, but not quite to the advanced EMT level, and certainly not to the level of a red patch true blue paramedic. Whether you're in this state as a Texas red patch or whether you're in another state, we teach the National Registry standards. We don't teach to the Texas standards. You'll find many states do not recognize the curriculums that use Texas EMS because Texas EMS falls below the minimums of the National Registry. One of the advantages and distinct advantages of PERCOM is that we teach the National Registry, which means you're eligible in all 50 states. And that could be advantageous. Many of us believe that you're probably parked in the state that you're in, but one thing I found in my 65 years of being alive, especially being with the military, is you don't know where you're going to end up, and you don't know where life is going to take you. Subsequently, you're going to run into all kinds of systems, no matter what state that you go into, that are going to use certain medications and many won't. In this particular course, using the Bledsoe book, the Pearson book and such, which is where a majority of the questions are taken from for the National Registry, in addition to Caroline, in addition to the the American Association of Orthopedic Surgeons, the AAOS, the original orange book that started this whole thing back in the 70s. You're going to find that these questions, mostly based out of this slideshow when it comes to pharmacology, as it relates to pain management, and then sedation, and then paralytics. So as to pain management, sedation, medications, and paralytics, we're going to introduce all three subjects over the next 3 months. They're going to cover the entire topic that you're going to require for the National Registry. I'll try to emphasize the points that I know that have been tested, and I'm also going to cut out of the slideshow things that I know are not going to be tested, or things that I know that no system in the world carries these drugs, at least no system in the United States carries these drugs with any kind of regularity. If you get into a system, let's say you move someplace, become a firefighter, paramedic, or an agency paramedic someplace in the United States, obviously those EMS medical directors may or may not be allowed to use certain medications because state law can govern all this. So the beauty of the National Registry is you're going to know it all. But for the National Registry exam coming up, cycle 6, there's a few drugs that you're going to absolutely need to know. As far as calculations are concerned, you may get one question that involves calculations. For those of you who took the PharmQual test through PERCOM and such, that's about all you're going to need to know is how to do those questions to pass the PERCOM class, and you'll probably only see 1 or 2 of those questions come up on your bank of questions during your National Registry exam. Remember, as soon as you sign on, 150 questions at random picked from all 7 topics are downloaded into the computer in an adaptive style. And what that means is if you start answering questions very easily, let's say with the respiratory management, you start answering 2, 3, 4 questions in a row, they start getting progressively harder until they figure out which one you can't finally answer, and then it drops back, scores your points for that section, and moves along. And unfortunately, all the questions are intermingled, so only a computer can keep track of all that. In any 10 questions, you can have all 7 subjects tested. But that's not meant to rattle you. That's meant to keep you quick on your feet. Now, it's a 2.5-hour exam. Most people don't have to go to 150, although some do. I've heard of some people answering these questions and passing the test within 75 questions, and I've heard of people failing within 75 questions. In other words, they bombed it so bad that even if they got the other 75 correct, the evaluation is that one person doesn't know his stuff. So you start hitting between 90 and 130, and all of a sudden it ends. You've got a pretty good feeling that you probably passed it. So, and don't ever get caught in that quandrum that I hear all the time on the National Registry when students get done is, oh, I answered the last question correctly and I know it was correct and it ended, so I know I passed. Wrong answer. It tests all 7 categories. You finally answer the one question in respiratory, but you find out that the other questions in cardiology, EMS operations, and all the other areas that are tested, the computer's already made a decision about. So don't get caught on that fallacy or myth as well. Okay, so with that introduction, we're going to start sedation and pain management. We're going to go past some objectives here a little bit. All right, so when it comes to indications, contraindications, we're only going to cover 2. We're going to cover morphine and fentanyl. That's about all that anybody ever carries. And that's just about all that we ever test on the National Registry. Morphine is the quintessential, no kidding, first narcotic ever that was out there that actually was worth a damn. Now, heroin is a diacetylated morphine. It's the most powerful analgesic in the world. Obviously, it's illegal. But heroin is the know-all, see-all. When it comes to legal medications, as far as being used in hospitals, pre-hospital care and such, all medications that are out there are put on an equal basis with morphine. so that 10 milligrams of morphine equals this amount in fentanyl, or this amount in Dilaudid, or this amount in Demerol. In other words, equivalent doses. So we'll start getting into that. We're going to cover a little bit of a little bit of normal physiology when it comes to the brain. There are a couple of things that I'm going to emphasize, and I'll make sure that I emphasize them with you so that you can copy it down correctly, and I'll linger on that slide for a little bit because these will appear or potentially appear on your exam. But we're only going to talk about morphine and fentanyl. Nobody uses Demerol and Dilaudid. Good luck finding that on an EMS rig someplace. Okay, the three that you see here, nalbuphine, butorphanol, and ketorolac. The last one is the only one we're going to talk about, ketorolac. That's Toradol. That's the big medication that we're using as an anti-inflammatory. Its most useful purpose is anybody who's got a kidney stone. That's the big bad one. Also, you want to use it if you know for sure that your patient has some sort of inflammatory issue. You don't use it in trauma. Now, when I go back to morphine and fentanyl, I'm going to give you its common uses and such, and where most competent protocols state when they're allowed to be used and when the alternative can be used. Now, if anybody has any questions, I got the chat box pulled up, so all you got to do is type it in or unmute and just interrupt me by saying, I got a question. I'll hear it, and then we'll hear your question. And then we'll answer as best we can. I try to keep this informal, but keep your pen and paper right in front of you because we're going to go over a few things that you will see on your exam. Now, when it comes to paralytics, neuromuscular blocking agents, we have two types. We've got depolarizers and non-depolarizers. So succinylcholine is the classic quintessential depolarizing agent. And then the non-depolarizers, pancuronium and atracurium, they're non-depolarizers, but the question now becomes is, gee, as a paramedic, I want to paralyze this patient, but I don't want him paralyzed for, 90 minutes. Or I may use Zemuron or rocuronium or becuronium. Most systems use rocuronium or becuronium. Most systems are going to rock, abbreviated rocuronium, because it's the shortest acting. It's about 30 minutes. Now, succinylcholine is very short acting. It lasts only about 10 minutes, maybe 15 if you're lucky on a good day. But for the most part, they'll reverse within 5 to 10 minutes, and that's not going to be fun especially if you belong to one of those agencies where you're the only paramedic in the back of the rig with the patient, and you got an EMT with you who can't push drugs. You don't want to be pushing a drug every 5 minutes. I just soon give them one paralytic for 30 minutes, and that'll be the last time I have to worry about that and get them to the hospital. So we're going to talk about some advantages here as well. Becuronium, a little bit shorter acting than pancuronium, but longer acting than rocuronium. And of course, rocuronium is probably the shortest acting of the non-depolarizers. Now, as I flip back to the previous slide, you're going to find something that I ask on every single graduate interview without exception. I'm going to look you straight in the eye, and I'm going to ask you, give me 4 contraindications for succinylcholine. And what you're going to tell me is, I won't use it in trauma. I won't use it in head trauma. I won't use it in trauma where there's been a lot of muscle mass damaged. And I won't use it in burns. And I certainly won't use it in situations where there's high potassium. So, closed head injury, crush injury or massive trauma, burns, and high potassium. Now, you can always say, well, geez, what if they're allergic to it? Well, okay, that's a given. Patient states I had succinylcholine when I was in surgery once and I almost died. All right, there's a clue. Avoid it. All right, so we're also going to discuss some of the induction agents. In other words, what am I going to give to the patient to make them quiet, to settle them down, or best yet, since I'm going to intubate them, make them go unconscious. It's going to settle them down to the point where I can suppress their GAD reflex. So we're going to talk about midazolam, which is Versed, ketamine, and etomidate. We're not going to talk about diazepam. That's the old Valium. And we're not going to talk about propofol because this is a deep anesthesia kind of medication that we don't use in the field at all. They suggest it on the slides and mention it because you'll see it in the emergency department as part of ventilator management, especially short-term ventilator management. Thank you. But you're not going to see it in the field. There's been a lot of bad press with propofol. As you know, this was the medication that the cardiologist used to treat Michael Jackson to help him go to sleep at night. And unfortunately, he wasn't skilled in airway management. No cardiologist is. And subsequently, Michael Jackson passed away. This is the propofol. This is the Diprovan. This is the medication that you heard about. You can recognize it. It's an anesthetic that's solid white. It looks like milk. Some of you may have seen it in your rotations. If you haven't had the rotations yet, be looking for it. Propofol's the white milk stuff. But we're only going to talk about three. We're only going to talk about Versed, which is the midazolam, the ketamine, and the etomidate. All right, then we're going to talk about rapid sequence induction, intubation, and pharmacologically assisted intubation. So let's start with analgesia tonight. Next month, we're going to do sedation meds. The month after that, we're going to do paralytics. Now, all of these lectures are not going to go 1 full hour. The reason for that is I'm old school, is that I read the studies from the 60s and the 70s and then the mid 80s that said that you shouldn't go more than 40 to 45 minutes on a lecture if I'm going to keep your attention. I can extend that a little bit and get your retention up over 70% if I include a PowerPoint with it. But I'll never get you to 100% unless you are actually actively outlining these chapters. So you go to your table of contents, you go to pharmacology or analgesics, and then you say, okay, and you start reading it and you start putting it in your own notes. You want to get through the National Registry in 80 questions and pass it? Start outlining your chapters. Takes a little bit longer to study, but it sits beaten there with a yellow or a green or a blue highlighter and highlighting stuff, hoping that somewhere along the line, the knowledge is sucked up from the paper into the marker, through your hand into your brain. All right, I can tell you that has about a 30% retention rate. 30% doesn't pass anywhere in the world. So actively outline your chapters. Actively outline the PERCOM lectures. Don't be passive, be active in outlining. Use your table of contents as a template, but make sure you're writing, not typing, writing this stuff in your own handwriting so that you can retain it. That has over 80% retention of the material. 80% passes just about everywhere. Certainly will pass the National Registry, which is only 70%, so you'll have plenty of room to spare. All right, so when you look at the primary reason a patient calls EMS, it's because I'm having fill-in-the-blank pain. I got a bad headache. It's the worst headache of my life. I have chest pain. I have abdominal pain. I just got crunched between 2 cars and my legs are pointing in all 4 directions. These people are going to be having a lot of pain. And for each of these instances, you're going to use a different medication. You may only use one pain medication because that's all your EMS medical director allows you to do. Or state regulations has said, no, we don't want you using dangerous stuff. California is very famous for that. I don't know why they don't trust their paramedics. Hell, birthplace of paramedics was there with the show Emergency. However, California hasn't done a lot of things well since the 80s anyway, so this just falls in the line. Now, when it comes to the medications, analgesia for providing relief, we're going to talk about a couple of modalities. So if you're going to align a person's fracture because it's an open fracture, and you're going to reduce the fracture by using a hair traction splint if it's a femur, or if you're going to put some sort of sling on the patient and yet there's just too much pain involved, we may want to use one of two medications. Same thing for if the patient is having a lot of pain, but their pain is out of proportion, that are screaming and hollering. We've all sprained our ankles. We've all had lacerations. And yet some people come in the emergency department, I can numb them up real quick locally and suture them. Other people, I have to give Versed or fentanyl or ketamine just to calm them down so I can hold them still so I can suture them. It doesn't mean that they're weenies. It doesn't mean anything like that. What it means is that patients will perceive pain differently depending on their brain, their stimulus, and of course some of their cultural and environmental factors. So we'll talk about that in a minute. Now the analgesics we're going to talk about again is going to be morphine and fentanyl. Some places still use nitrous. In Chicago, when I was there back in the late 70s, early 80s, we had nitrous. After about 1 year, they took the nitrous off the rigs. It just wasn't working out for the patients. And some of the paramedics would test the nitrous at morning or at night, and there were some abuses there and such. And even though it's not a dangerous med, it got quite expensive because 1 in 10 patients were getting it. The other 9 times it was either leaking or it was a paramedic that was kind of sniffing it themselves. There's kind of a funny story behind it, but it's the truth. So some places still use nitrous, most places don't. And then to round it out, you all know about ibuprofen and acetaminophen. Ketorolac is going to be the other one that I'm going to talk about, and that's the Toradol. There's the anti-inflammatory. So let's start off with morphine. Morphine is the big one. It's the prototype. It's the one that all other analgesics are compared to. And each one of these analgesics have different properties to them, but for the most part, you're not going to be tested on properties. You're not going to be tested on what receptors they stimulate, except to know the types of receptors that are out there. You may get one question. I have a slide coming up here in a minute on that very subject. Now, you're going to run into 2 words out there in your life. One column, I want you to put the word opiate. The other column, I want you to put the word opioid. They're different. Opiates are true blue, no kidding narcotics. Opioids are narcotic-like medications that still affect the mu receptors, but don't have the same, if you will, the physiological analgesic properties that a true opiate would have. For instance, tramadol is an opioid. Stadol is an opioid. Nubane, opioid. These are narcotic-like, but they either have some sort of antagonist built into them or they're not true narcotics at all. From a test standpoint, it's going to be mostly opiates that are tested. So when we look at the receptors, when you look at the mu receptors in the delta and the kappas and such like that, you don't have to worry about the last one. You're going to see that there's various places in the entire body where pain is perceived. Now, you get a gunshot wound to the leg, we know that that's where the pain originated. But where is the pain perceived? It's perceived in the brain. It localizes it very well to the area that you got hole from the gunshot or the stab wound or the open fracture. We know that that hurts. But yet, when you give a medication that blocks the transmission of that pain stimulus up to the brain, you're given a medication that's blocking where the pain stimulus is received. And that's in a part of the brain, the spinal cord, or even the GI tract, called mu receptors. And the mu receptors are pretty much all over the place. These are the big ones. This is the one where the Narcan actually attacks as well and kind of displaces the narcotic. But with the mu stimulation, in other words, when the narcotic hits there and blocks the mu receptors, you can get physical dependence, respiratory depression, euphoria. You get the real tight pinpoint pupils, the so-called meiosis, and physical dependence. Now, the only things you're going to need for the test here is going to be respiratory depression, meiosis, and physical dependence. Those are the big characteristics of a narcotic medication because they bind to the mu receptor. Now, delta receptors are only located in the brain. It's in an area of the corpus callosum of the brain that, quite frankly, you don't have to know that part of it, but just know that if you bind to the delta, if you have a drug that binds to the delta receptors, you can also get physical dependence, even though you do have good anesthesia. And you're not going to worry about kappa and nociceptin because they're not tested. So it's really going to be the mu receptor. You got to know about the meiosis, the respiratory depression, the physical dependence. Okay, so how about, hey, what's equal to what? So we look at the opiate conversion chart. This is the big one. This is the one where an IM or an IV administration of the medication is equal to 10 milligrams of morphine. That is the gold standard. Geez, when you look at, well, let's take, let's see, fentanyl here. It's the only other medication you're going to use. 0.1 or 100 micrograms, and watch the way I'm talking about this, people. Micrograms. That's going to be 0.1. That means 100 micrograms is going to be equal to 10 milligrams of morphine. So when somebody says, oh, I only want to give 25 of fentanyl, or I only want to give 50 of fentanyl, well, in the back of your head, then you should be going, geez, if I'm going to give 50 mics of fentanyl, that's only 5 milligrams of morphine. Does this patient warrant only 5 milligrams of morphine? In other words, will 50 micrograms do the trick on this patient? Well, if they got a laceration to their leg, or if they got, if they're real small, or if they're children, the answer is probably going to be yes. But if you got some big hulking person there sitting around 200 pounds, 220 pounds, 100 kilos, you're going to find that 100 micrograms of fentanyl or 10 milligrams of morphine may not cut it for this patient. And so, for instance, I was on a motorcycle accident recently with an EMS system that I'm their medical director, and this guy was one of those big Harley dudes. I mean, he had to be 260, 270. And we ended up giving him 400 micrograms of fentanyl IV push on the first dose for his open femur fracture, just so I can get the hair traction split on him. I mean, you may have to go to big doses. The beauty of fentanyl, it wears off within about 10 minutes. We use it in surgery so that you don't feel the surgery. When we open up the chest, crack the breastbone, spread the ribs, and start working on your heart, you're going to be damn glad that you got fentanyl. The anesthesiologist is given 100 micrograms of fentanyl, depending on how big you are out there. If you're 75 pounds, fine, you'll get something light. If you're 220 pounds, you're going to get the bigger dose. But fentanyl is the one that blocks the pain, the mu receptors, so that you don't feel the pain of surgery. Well, if it's good enough for surgery, it's good enough for your trauma patient out there. So don't hesitate to use 100 to 200 micrograms of fentanyl when you're giving pain relief to a patient in a trauma situation. Fentanyl, by the way, and I want you to underline this, bold print it and stamp it to your forehead. Fentanyl is the narcotic drug of choice for trauma. Fentanyl is the narcotic drug of choice for trauma. Okay. So, morphine is your next one. Fentanyl lasts in only about 10 to 15 minutes. Morphine can last 30 minutes to an hour, sometimes even longer. You can start a patient who's having non-trauma pain on morphine. 2 milligrams IV push for chest pain in a 90-year-old woman who's complaining of headache or chest pain. 4 milligrams for just about everybody else. You can go 6 to 10 milligrams for big patients who are having major pain. Now, what's the difference between morphine and fentanyl? Morphine dilates the pulmonary vasculature. It dilates the systemic vasculature. It relaxes the patient. And by dilating the pulmonary vasculature, we find this as a distinct advantage for using in congestive heart failure patients. That's why it's part of MONA, morphine, oxygen, nitroaspirin, morphine. So with the morphine, we dilate the pulmonary vasculature. It accommodates fluid and actually helps with the osmotic reacquisition of water from the lungs into the pulmonary vasculature. It also calms the patient down, and it also kind of decreases myocardial contractility, which during a heart attack is very, very big and very important, since we're trying to decrease the oxygen requirement for the heart muscle during a heart attack. So by relaxing it a bit, you got to watch for the drop in blood pressure. But if your blood pressure can handle it, sneak up on them. 2 or 4 milligrams IV push, repeat it in about 5 to 10 minutes, repeat it in 5 to 10 minutes till the patient gets pain relief. Now, morphine can drop blood pressure because there's a release of histamine. Histamine is not that big of a deal, but in some patients, they can have a dramatic drop in blood pressure. Here's the advantage of fentanyl. Fentanyl has the least amount of stimulation to the cells that release histamine, which is why fentanyl is preferred in trauma, because it won't drop the blood pressure. So fentanyl does not drop the blood pressure because it releases the least amount of histamine. It goes right to the mu receptors, very potent, and stimulates the mu receptors, which blocks pain, period. Fentanyl is the drug of choice in trauma patients. Morphine is the drug of choice in cardiac pain. Some systems only carry fentanyl. They don't carry morphine. If that's the case, so be it. But you won't find any systems that will want to use morphine in trauma. That we don't like. We don't like doing that at all. Fentanyl is your drug of choice for trauma. All right, the other medications that you see there, the hydromorphone is Dilaudid. Geez, everybody likes that. That D drug. What's that D drug? I forget what that D drug is. Yeah, Demotrin? No, it's Dilaudid. People try to pull that crap on us all the time in emergency room. And it's funny to watch them, actually. Meperidine is Demerol. Now, that's an older narcotic. We use it generally IM. Only used it once IV. Had no difference of effect on the patient, but of all the narcotics, meperidine or Demerol releases the most histamine. And so you get the biggest drops of blood pressure with Demerol, which is why we very rarely, if ever, anymore use Demerol, even in the emergency department. I may use it for somebody who says, hey, can I have one for the road? Sure, I'll give you some Demerol. It'll last about 4 to 6 hours, and hopefully you'll go to bed, and that'll be the end of it. But from an EMS standpoint, it's going to be morphine for the cardiac, fentanyl for the trauma. Okay. So we talked about this a little bit. This is morphine, mechanism of action. CNS depressant, analgesia, and sedation. Okay. Increase venous capacity by decreasing venous return. In other words, increases peripheral venous capacitance by dilating the veins. By dilating it, you increase the vasculature to accommodate more blood or to draw fluid out of the tissue back into the bloodstream. You have to be careful with morphine. If it's contraindicated when your patient's hypotensive. It's like not a good thing because morphine will drop your pressure. Are we worried about respiratory depression with the narcotics and with fentanyl and such? Well, yeah, but we're paramedics. And so we can do things like CPAP, drop an airway, bag a patient. We can even intubate a patient if the trauma is that bad. I'm going to intubate you anyway. So I'll use the fentanyl, I'll use another medication, and I'll use a paralytic that won't affect your head or your trauma and put them to sleep. Don't worry about respiratory depression. You're trained paramedics. You can handle respiratory depression. What becomes a little problematic, especially if you don't have a good line where the patient's just a bad patient from a standpoint of they're really in serious or critical condition. What you don't want to do is be dropping their blood pressures. And so that's a distinct disadvantage of morphine. You may ask a question, hey, geez, can I use fentanyl then in a hypotensive cardiac patient? The answer is absolutely, because it's not going to drop the blood pressure any further. Unless you push mega doses of fentanyl and you push it like you're caulking a window, yeah, then you're going to have some problems. But if you push it over 1 to 2 minutes and you use a reasonable dose and such, you're going to get good analgesic effect even on a hypotensive patient, and you don't have to worry about dropping their blood pressure. You do have to worry about respiratory depression, but like I said, you're paramedics. Okay, so you're not going to get tested on the pharmacokinetics, how long it lasts and such like that. So put your pens down for a second. You just know that when you give morphine, its effect ID is almost immediate. You can give 4 milligrams IV push, 10 milligrams IV push, and within 15, 30 seconds, I mean, your patient has got some pretty decent pain relief going on. It peaks in 20 minutes, lasts about, they say 2 to 7 hours. My experience has been, it's been about 1 hour. And you're redosing patients. As a matter of fact, many protocols tell you to go ahead and give 2 to 4 milligrams IV push every 10 to 15 minutes as needed for pain, because it just doesn't last that long. And you may want to build up a little bit. You may want to say, well, I don't want to drop his blood pressure real quick. I'm going to give you 2 and I'll repeat it in 10 minutes. So if you want to sit there all day and keep doing that, that's fine. And you're not wrong to do that. But you'll realize as you start becoming more experienced paramedics, or if some of you actually take on more, such as critical care paramedic, flight medic, maybe you'll rise to the very top and become military helicopter medics, or start advancing your career in a nursing, PA, NP, or physician. You're going to realize that giving pain relief right away makes the rest of the case go a lot smoother when your patient's not screaming, hollering, and asking for pain relief every 2 minutes. So we use morphine for MI, kidney stones, orthopedic injuries, burns, and other forms of trauma. It's not the drug of choice. Morphine is the backup drug of choice. Look, if your trauma patient's sitting there with a 180 or 100 blood pressure, have at it. Give them the morphine all day, but watch for the hypotension. And then its contraindications are going to be the top 4. The bottom one, undiagnosed abdominal pain, fell by the wayside 15 years ago. I'm not sure why Pearson still includes it. I can tell you the National Registry, we don't include undiagnosed abdominal pain, and I'll tell you why. Back when I first got done with training in the 80s, we evaluated a patient's abdominal pain when they came in the emergency department. We hesitated to give them pain medicine because I was going to potentially have to call a surgeon after I got the blood work back and such to come down and evaluate the patient as well. If you gave morphine in the field, I couldn't tell where the pain was at. And so we had to go by blood tests and other things, and then had to call the surgeon, wait for the pain medicine to wear off, and then reevaluate the patient and then decide, are we going to operate this patient or not? Well, guess what happened in the year 2000 going forward? Bill Gates and his brilliant invention of giving us computer technology and such, now we have programs which help us look at the inside of the body through CT scan or through MRI. So we don't make diagnoses of abdominal pain based on physical exam anymore. It gives us a good head start, So when I get a patient in the emergency department, you tell me, look, I had to give the patient 200 fentanyl or 10 of morphine because his right upper quadrant pain was so intense that he was vomiting and I need to settle him down. I'm going to say, hey, great, shake your hand, pat you on the back, say, nicely done, patient's happy, I'm happy, everybody's happy. And I shoot him over for a CT scan or I shoot him for an ultrasound. We base our diagnoses on our technology now, especially when it comes to abdominal pains or head pain. So I'm not worried about you giving pain medicine for abdominal pains. Your objective is to make them comfortable for the trip in. But the first four that you have here, the 4 H's, the head injury, the hypotension, hypovolemia, and hypersensitivity, okay, those are legit. If you're allergic to it, fine. If your blood pressure is low because of hypovolemia, don't give it. If you have a head injury, we'd prefer you not give morphine. You can give fentanyl, but you're not going to, we don't want you to give the morphine for a head injury. Remember, head injury is trauma. What's the drug of choice for trauma? Fentanyl. Watch the LDO asthmatics and everybody. The reason why they mention the asthmatics is because morphine can release histamine. Histamine is the primary mediator, which causes bronchoconstriction. If a person has asthma, they have highly sensitive mast cells in their lungs, which when they come in contact with the morphine can release histamine, and it can make an asthmatic worse. So we tend to use fentanyl in those cases. If your asthmatic's really that bad, shoot them with the fentanyl, give them the Versed, give them the rocuronium, and get them intubated. There's nothing worse than watching an asthmatic witness their own suffocation and then go into cardiovascular collapse because we were afraid to use a drug or intubate. But you'd use a fentanyl in an asthmatic. Patient's not asthmatic, have at it all day with the morphine, not a problem. Side effects, watch the constricted pupils. That's called meiosis, and that's going to be one of the signs that you've got a patient who's on a narcotic, pinpoint pupils. There's only 3 things in the world that cause pinpoint pupils. Copy this down. Pinpoint pupils. Number 1, really bright light. Kind of a no-brainer. Number 2, narcotics. Number 3, pontine strokes, a stroke in the pons. So if your patient's got pinpoint pupils and they're 18 years old, I'd probably be reaching for the Narcan. If your patient's 75 years old and is also got slurred speech, can't move their arms or legs and such like that, I'd be watching for a stroke here. So it depends on your demographics and, of course, what the patient's history is. But for the most part, narcotics or strokes. Pontine, pons, pontine, they call them pontine pupils for a reason because they're so pinpoint. They're so small, you wonder if they even got a pupil. I mean, they're really tight. Okay. Standard dose, 2 to 10 milligrams IV push. You can keep going at 2 milligrams until they're pain relieved, or if they start showing low blood pressure, if they start getting real groggy, pulse oximetry 80, 85%, throw a non-rebreather on them, and you can kind of stop at the morphine at that point. I don't want you to get into the morphine until apnea dosing. That's probably not a good way to live. But certainly you can sneak up on them at 2 milligrams at a time until you start detecting a drop in pulse oximetry, or drop in their mental status, or if their blood pressure starts dropping. Now, they talk about antiemetics. Many systems, if not all systems, carry Zofran. Prefer to give it IV because it works faster, especially if you're giving it with a narcotic. But you can give it sublingual as well, a dissolvable tablet, and this stuff works wonders. We give it to chemotherapy patients 16 to 50 milligrams IV piggyback over 10 to 15 minutes before we start chemotherapy. It prevents people from throwing up during the chemotherapy and even afterwards. It's been a godsend medication, especially for chemotherapy patients who used to get chemotherapy, the cancer patients get chemotherapy and then they spend the next 2 hours just vomiting. Phenergan, Reglan, and all the Encapazine, all some of the other happy stuff that's out there, some of the older medications, they still do good job. But Zofran has been just superior, and it's replaced almost all the other medications when it comes to antiemetics. So if I give morphine, I'm going to give 4 Zofran with it. If they're vomiting, I'm going to give them 8 Zofran. Can I give them 20? Sure. Can I go up to 50? Absolutely. It's got such a wide safety profile that you can't overdose anybody on it. Some people say, well, can you use it in pregnant patients? Well, we had a discussion about that over the past 2 to 3 years, and it started appearing in articles and such. Maybe we shouldn't be using Zofran because we're seeing an increased number of miscarriages. But then the CDC came out with this big study backed by the National Institute of Health, and they decided, you know what, it's not causing miscarriages. So we're back to using Zofran in pregnancy, especially those gals that are in their first trimester. I'll give them a little morphine. No, they're not having pain, they're just vomiting. Yeah, the morphine relaxes them now, and the Zofran does a real good job cutting out the vomiting. All right, we're going to skip over Dilaudid, but you're going to find that it has the same profile as morphine. 1 milligram of Dilaudid equals 10 of morphine, and you may run into it out on the street when it comes to patients that either got a hold of it and are using it illicitly, or cancer patients who may be on Dilaudid just to keep their pain under control. And it's a great medication from that standpoint. Unfortunately, it's one of the most abused medications that are out there, and you can get addicted to that stuff so quick that it's, I mean, really just being on it for 1 week, just being on hydrocodone, Lortabs, can get you addicted pretty quickly. So some patients will refuse narcotics. Most patients, however, will welcome the pain relief. And no, not everybody in the country is going to become a drug addict after 1 dose or 2 doses or even 1 day. Okay, we worry about that in the hospital. You don't worry about that in the field. Okay, all right, the next drug we're going to talk about, and then we're going to wrap this up, is going to be fentanyl. Now, fentanyl is the one that you're hearing about in Ohio especially, but in Texas, we got a problem. Oklahoma has a problem with it. California's got a problem with it as well. New York City, New Jersey. These are all places where the methamphetamine is big, and they're cutting the methamphetamine with fentanyl. And the reason why they're doing it is to enhance the high. Now, fentanyl is one of the most powerful narcotics on earth. It's right behind heroin. It's 88 times stronger than morphine. In this case, 100 micrograms equals 10 milligrams. So you can almost say it's 100 times stronger. It's potent. And like I said, we give it in micrograms. We don't give it in milligrams. We give it in microgram doses. And this is the drug that we use in surgery to make sure that you're not feeling any pain during your surgery. I can paralyze you for the surgery, but you'll be wide awake. You just can't move, but you'll feel everything. I give you a sedation drug like Versed or propofol in the appropriate setting, and then I enhance it with fentanyl. And the fentanyl is going to keep you pain-free for the entire surgery. When you wake up and we recover you from the fentanyl, you're going to have surgical pain, but believe me, you will not have felt the surgery. And that's the advantage of fentanyl here. Again, the least amount of histamine release, the drug of choice in trauma, very potent. So 50 to 100 times more potent than morphine, we covered that, but its action is only 10 to 15 minutes. In some cases, it can be as low as 5. So you want to kind of take it easy on a patient. You get on the scene, this is going to be one of your scenarios. You get on the scene of a 28-year-old male who's got been in a motorcycle accident and has an open femur fracture, but is also unresponsive. Are you going to give him pain medication? Well, he's unresponsive. He's not complaining of anything. Duh. Yeah, actually, he's feeling it. He just can't respond to you, but he's feeling it unless he's like GCS3 out of it, gone. You're going to want to give fentanyl before you intubate a trauma patient or a burn patient or a closed head injury patient that you're going to come around and intubate, because it's a great pain reliever. And yet, it doesn't affect the blood pressure. So you give it in the field, by the time they get into the emergency department, it's just like, hey, doc, I could use some more pain medication. No problem. I tell the nurses, pull me another 200 micrograms of fentanyl. And while they're out of the room, I assess the patient. It's that quick, 5 to 15 minutes, and it's off. And this is why it's a favorite in EMS, because it gives the patient adequate pain relief. And yet, when they get to the emergency department, it's just about at the point where it's wearing off. So watch your respiratory depression, of course. And if you give too much of it, like all these dorks out there that are taking methamphetamine with the fentanyl, and they go to bed and they wake up dead the next morning. A lot of overdose deaths as a result of the combination of methamphetamine and fentanyl, because they're taking the equivalent of 400, 600 micrograms of fentanyl in 1 or 2 snorts, or shooting, or orally ingesting it. The fentanyl's killing them. But at that doses, it will kill you. 600 micrograms will kill you. And people who say, geez, I want a better high, so if 1 is good, 2's got to be better. Well, there's 1,200 micrograms of fentanyl, and that, as you can tell by statistics in the country with fentanyl, it's killing people. So peak effects, 3 to 5 minutes. They say it lasts 30 to 60 minutes. Good luck with that. Everybody's asking for pain medication again in 10 to 15 minutes. We use it for either severe pain, and it can also be used in RSI for induction of intubation and such, and we'll talk about that later. And remember the common sense contraindications: hemorrhage, hypovolemia, any kind of shock at all, or hypersensitivity. Look, if your patient's pressure is 60/0 and the patient has altered mental status, you want to touch them with a light dose of fentanyl. That's up to your medical director and your protocols. It's contraindicated for hypotension because it still has the capacity to do that in the setting of trauma where the patient has had fluid and blood loss. Okay, so that's the shock. That's the severe hemorrhage. You don't want to be giving it when they're really hypotensive from that. Tank them up at first, and if you got to get them to calm down or something, go ahead and sedate them with another medication like ketamine, which doesn't influence the blood pressure at all, and at least get them asleep so that you can get them into the hospital. And watch for the bradycardia. Now, you're not going to be tested on the liver and kidney dysfunction or anything like that. Side effects is going to be the same. If you push fentanyl too fast, your patient goes rigid. They'll go apneic, but they're going to go rigid. You're going to look and see that they're going to stiffen up. They're going to be so stiff you'll want to take them surfing as the surfboard. They will stiffen up that bad. And subsequently, you have to be slow in your fentanyl push. Give it too fast, they go rigid. Or worse yet, they go bradycardic. And I'm not talking 60 to 50 to 40. I'm talking adenocard type bradycardia, like 20, and the patient can go syncopal on you. So watch the fentanyl. Make sure you're giving it over 1 to 2 minutes. But it doesn't stimulate vomiting like the other ones do. Okay, you're going to get one question. You might get a question. It's in the bank, and it's the second bullet point here. And I want you to kind of know about it, only from the standpoint you're not going to have to know the drugs, but you're going to get a question on when not to use fentanyl or morphine. And the potentiation of MAO inhibitors, monoamine oxidase inhibitors, it's a blood pressure medication, but it's such an older class of medications. But you're going to recognize it because it's doxazocin, or it's Nardil, or it's one of those words that you look at and you go, did you get this filled in the United States? And the answer is, yeah. Some of the older doctors, family practice settings, still use the old MAO inhibitors. The only question you may get, and remember, it's a random bunch of questions that come into your computer when you sign in to take your test. One of the questions could address that second bullet. When narcotics are contraindicated. One of the answer choices could very well be an MAO inhibitor. As soon as you see MAO inhibitor, man, be looking, just let it trigger something in your brain that says, I can't use a narcotic with this. Now, the combination of the two the MAO inhibitor plus the fentanyl, the MAO inhibitor plus morphine is going to crash their blood pressure. And it's a 1 + 1 = 3 effect. Okay, so you took the MAO inhibitor by itself, it dropped the blood pressure. You give fentanyl by itself, it could drop the blood pressure. You give them both together, it will drop the blood pressure. It's not going to drop it, it's going to crash it. So just know that. And it's 25 to 100 mics. Give it over preferably 2 to 3 minutes. We can also use it in a mucosal atomizer device, a MAD device. This is the most favorite thing for children. You put 25 mics into the MAD and you squirt it in their nose. And they get instantaneous pain relief because fentanyl, just like any other narcotic, once it hits mucosal tissue, is rapidly absorbed. I've seen even in the emergency department when they've got a lot of bleeding and such like that from the nose because of facial trauma, sometimes we'll even squirt it under their tongue. It's not recommended, but you know, as long as I'm not dosing all day underneath the tongue, 2, 3, 4 doses not going to hurt the patient. But typically we atomize it into the nose and the patient gets total pain relief very quickly. It's a great way to settle children down at 25 mics, and you don't have to start IVs, you don't have to do anything. Just keep the fentanyl in their nose and they are good to go. And you got a nice quiet child for the rest of the ride. Now, there is something you're going to have to know from the pediatric dosing standpoint for pediatrics. Pediatric dosing for children is going to be 1.7 to 3.3 mics per kilogram. And use it with a MAD device, but you're going to have to know the 1.7 to 3.3 microgram per kilogram. They're not going to have you do a calculation on the test so much as they're going to say, you use fentanyl on a child who weighs, let's say, 25 kilograms. They're going to make it easy for you. So you're going to take the mid-range there and you're going to go, well, let's see, 1.7, 3.3. I'm not going to do magic calculations here because why? Because it's 4 in the morning and I can't do that kind of math. So you whip out your iPhone or your Android or your portable calculator and you calculate. Can you use calculators on the scene? Absolutely. Make sure you're safe. Make sure you're not overdosing the patient. But I use 2 micrograms per kilo in children. And that works out just perfectly fine for all of them. And it only lasts for 10 to 15 minutes. So you don't have to worry about the patient going apneic. And what happens if they do go apneic? Well, then you put an oral airway in them and you bag them. Why? Because you're trained paramedics. You're not worried about those kind of side effects. But know that 1 to 2 micrograms per kilogram can be given IV push or by the MAD device, and you can deliver your fentanyl very safely. All right, we're going to wrap it up here. That's the end of the narcotics I wanted to talk to you about. And what we're going to do next time that we meet is we're going to start on the sedation, wherever you're at. Or we'll cover ketorolac next time that we start. Does anybody have any questions what we've talked about thus far tonight? Stephen, Marguerite?
I don't have any questions. I just wanted to say thank you for the lecture today, and I thought it was really good.
Well, I appreciate you being here. And Dusty, you're welcome. And also remember, you guys, get in there on this section. If you do any other section at all, do it on pharmacology. Outline it in your own words so that you understand all of the pharmacology you're going to be talking about, because it's a big part of your airway management and your pharmacology combined. Marguerite, any questions?
No, I just wanted to say thanks for that tip about using fentanyl in the MAD device with kiddos. It's going to be real helpful.
Yeah, well, I tell you, you pull that MAD device out on a kid and you squirt him and you got a brand new kid. Sometimes I wonder if I shouldn't keep around here for my grandchildren. Hey, Dalton,
yeah, they might get mad for a minute when you squirt it. I know.
No questions. Thank you, sir.
I'm sorry, Marguerite?
I said they might get mad at you for a couple seconds for squirting something up their nose, but then a couple seconds later, they'll forget all about it.
Yeah, then they start giggling this really weird giggle laugh like you're dealing with something out of the one of the horror movies. Jeff, you got any questions?
No, I'm good. Thanks very much for that.
Ray?
Nope, thanks.
Dusty, one more time?
In that minute, are you like riding over there?
All right, Ryan.
No, sir, I don't have anything.
All right. We'll see you guys next month. Please be here for it.
Thank you.
All right, Jane, take care.
Thank you. Good night, everybody.
Good night.